Renal cell cancer is not one of particularly easy ones to diagnose and to treat. Why is that?
Well, one of the problems is that kidney cancer is often diagnosed in advanced stage. In about 25% of patients, metastases have already been developed, and of those patients who are surgically resected, where the kidney is taken out, about 25 to 50% of those will have the development of metastasis in the future, simply because the tumor is detected too late and after metastases have been set. So that's one of the reasons why kidney cancer is often a difficult cancer to treat, because even if you can take it out completely, a lot of these patients will develop metastasis.
What is the treatment management in different groups of patients?
So as long as the tumor is localized, which means there is no tumor outside of the region of the kidney, surgical resection, taking the kidney out, is the treatment of choice. There is no additional treatment needed if that is done and if the tumor has been completely removed. If patients have metastasis or develop metastasis, then we move into this field of targeted therapy, which we now use for kidney cancer in patients with metastasis.
Has there been any major progress in treatment of renal cell cancer in recent years?
So the whole treatment of kidney cancer has completely changed in the last 2 years. Over the last decade, there have been 6 or 7 drugs approved for the treatment of kidney cancer, which is almost 1 drug per year, which is unheard of. Before that, we really only had interferon and interleukin, which were unspecific immunotherapies, which only could be given to a small portion of patients. The majority of patients were no candidates for that, and even in that, those patients who had the treatment, the efficacy was very, very limited. So now, over the last 10 years, the whole field has completely changed. We have several drugs we can use. We have been able to more than double the survival of our patients. We now have long-term survivors. I have patients who have been on these drugs for years. And we are learning more and more how to optimally use those drugs and how we should sequence them. And there's a variety of new drugs now in clinical development, which will, over the next coming years, also add to our armamentarium in kidney cancer, and will continue to extend the life expectancy of our patients.
A group of special concern of the patients with renal cell cancer are the patients in late stage of the disease. Especially in Poland, they have very limited access to any treatment. How do you treat them in Canada?
So in Canada, we have a limited access as well, but access is obviously an important part of optimal outcomes, because you can only get optimal outcomes if you have the tools to get there. We now have very strong evidence for first-line therapy for patients with metastatic disease and for second-line therapy. There is increasing evidence that we should use these drugs also in third-line and fourth-line, and I'm sure that that will be established over the next years. When we use these drugs in an optimal way, then we can extend the lives of our patients quite significantly. If we don't have the access, then obviously we cannot make all the optimal treatment decisions, and then we cannot achieve the optimal outcome for the patients.